Welcome to this ESO educational webinar, and the topic of today will be the blood pressure management in patients with intracerebral hemorrhage. And we will go through the intensive treatment of the acute phase and the use of antihypertensives in primary and secondary prevention of ICH. We note that ICH occurs in around 15–30% of people and of strokes. And the important things in ICH is the work of treating the acute phase and also to prevent to reduce the risk of recurrences, but mostly the risk of expansions. And also we have to manage the prevention of recurrence and the longer term phase of ICH. I'm Anna Bersano. I'm the chair of ESO Education Committee. I work in Istituto Neurologico Besta of Milan and a vascular neurologist. And it's a pleasure for me to chair this webinar together with Professor Thorsten Steiner, that is the chair of Department of Neurology, Bersano Klinikum Frankfurt. And he's also professor of neurology and neurointensive care at the Heidelberg University Hospital, and he's also the chair of the ICH committee of ESO. And please, Thorsten, the room is yours to present the speakers.
Thank you, Anna, and hello everybody. It's a great pleasure for me to introduce our first speaker, Andrea Morotti. Andrea will speak about, is intensive blood pressure control effective in improving clinical outcome? Andrea is professor at the Department of Clinical and Experimental Science at the Neurology Unit at University of Brescia in Italy. Andrea.
Well, thank you very much for the kind introduction and for this nice opportunity. And thank you also, Anna, for organizing and contributing to this webinar. Let me bring up my slides. Okay. Okay, so I will try to answer these compelling research and clinical questions. So, is intensive blood pressure control effective in improving clinical outcome in patients with acute intracerebral hemorrhage? These are my main disclosures, and this is the outline of my presentation. So I will discuss a bit the background on ICH expansion. We'll go through randomized control trials that tested blood pressure lowering in acute ICH. We'll take a look at what lessons we have learned from these trials, and we'll then focus on subgroup analysis, trying to identify patients more likely or less likely to benefit from blood pressure lowering, and we'll look at challenges in clinical practice and future steps. So why is ICH expansion relevant? It is relevant because it is very common in acute ICH. It is associated with outcome, and it is therefore one of the more compelling therapeutic targets, as prevention of ICH expansion is probably going to have a meaningful impact on functional outcome. What are the key predictors of ICH expansion? The two key predictors were shown in a very nice meta-analysis from Rastam, Al-Shahi Salman and colleagues a few years ago. And the two key predictors are time from onset to baseline imaging and baseline ICH volume. And as you can see here from this very nice graph, the risk of ICH expansion is not linear with increasing time, and most of the expansion typically occurs very early in the natural history of the disease. And this is probably one of the first key messages of my talk, So hematoma expansion occurs early, and therefore prevention is strongly time-dependent. Other predictors of ICH expansion are antithrombotic treatment. We know that single and dual antiplatelet treatment increases the risk of ICH expansion, but it's really anticoagulation that it is associated with a significant increase in the odds of hematoma expansion. And this that you can see here is heparin-associated bleeding with baseline and follow-up CT showing massive hematoma expansion. We also have imaging predictors of hematoma expansion. You can see, for example, here a non-contrast CT feature, a hypodensity, and here a CT angiography spot sign. And we do know that when they are associated and co-localized, the risk of hematoma expansion is very high. And then, of course, blood pressure, the main topic of today's talk. These are hypothesis generating data from the first ATAC trial. And as you can see, there is a clear association between high systolic blood pressure and the risk of significant hematoma expansion. And this is somehow the background and the hypothesis tested in future trials. So systolic blood pressure reduction might improve functional outcome through a reduction in the frequency of hematoma expansion. So let's see what happened in clinical trials and why it hasn't been super easy to do clinical trials in this population. In 2022, there was this very nice methodologically robust meta-analysis that showed that systolic blood pressure reduction in the acute phase did reduce the risk of hematoma expansion. But this reduced risk of hematoma expansion did not translate into an improved shift in the modified ranking scale scores evaluated mainly at 90 days. However, we have novel evidence on the benefit of intensive blood pressure lowering, and this is probably the strongest evidence available to date. And it's a very large pooled analysis of all the INTERACT trials. We have 4 INTERACT trials, and this study included more than 10,000 patients. And as you can see here from the modified ranking scale distribution, there is a clear, significant favorable shift in favor of intensive blood pressure lowering when compared to guideline treatment group. Another very important message that this analysis has shown is that the benefit of intensive blood pressure lowering is time dependent. And as you can see, the sooner the better for prevention of hematoma expansion and improvement of the distribution of ordinal modified ranking scale. So let's see what we have also learned from randomized controlled trials, either positive, neutrals, or negative randomized controlled trials. First of all, we have learned that not all the trials were the same. You can see here, for example, that the guideline treatment arm of the ATAC-2 trial was very close to the intensive treatment arm of the INTERACT-2 trial. And what the ATAC-2 trial taught everybody is the lower limit of systolic blood pressure. So we now know that the sweet spot is probably in this region between 130 and 140, and this was also confirmed in a secondary analysis of the INTERACT-2 trial. But what we have learned in ATAC-2 is that pushing further down to 110 or 120 millimeters of mercury is not going to provide additional benefit in terms of hematoma expansion or poor outcome. But pushing the blood pressure too much is probably going to increase the risk of neurological and kidney side effects. So we learn that we should not reduce the blood pressure too much because there is no added value and we might just have an increase in side effects. Another important lesson learned is that we have also analyzed hematoma expansion as a binary variable. So hematoma expansion, yes, no. We now know that it might be meaningful to express and analyze hematoma expansion as a spectrum with different severity degrees. And this is what was done in a secondary analysis of the ATAC-2 trial. So the authors categorized hematoma expansion into mild, moderate, severe, and very severe with these validated thresholds. As you can see, when you look at the comparison between intensive and standard blood pressure treatment, intensive systolic blood pressure lowering provides a shift in the expected direction, so a favorable direction. And in particular, intensive blood pressure can reduce the occurrence of severe and very severe hematoma expansion. We have also learned that the relationship between hematoma expansion and poor outcome is a bit more complicated than we previously thought and assumed. We know that different regions of the brain have a different tolerance to ICH volume, and in particular, brainstem and thalamic hemorrhages have a very low tolerance to bleeding. So few mils of bleeding are enough to impact functional outcome and mortality, while lobar hemorrhages can somehow accommodate larger hemorrhages without a significant impact on outcome. And we translated this into hematoma expansion, and we observed that not all hematoma expansion will have a meaningful impact on functional outcome, but only hematoma expansion that brings the final ICH volume above a critical threshold will have a significant impact on outcome. And this critical tolerance threshold is much higher in lobar hemorrhages, while it is nearly half in deep hemorrhages. The volume threshold we identified was 36 mils in lobar bleeding and only 17 in deeply located hemorrhages. And among deeply located hemorrhages, the thalamus is by far the one with the lowest tolerance to ICH volume. We have also learned that time is brain also in ICH, especially in ICH. The first table that you can see here is a very nice secondary analysis of the ATAC-2 trial by Professor Chiesi. So the ATAC-2 trial was overall a neutral trial in terms of functional outcome, and it mainly recruited people within 4.5 hours from symptom onset. However, if you restrict the ATAC-2 trial analysis to patients presenting within 2 hours, so early presenters, you can see that systolic blood pressure lowering doubled the odds of good functional outcome. And this improvement in functional outcome was mediated by a nearly 50% reduction in the risk of hematoma expansion. So if we target people in the very early time window within 2 hours, systolic blood pressure does reduce hematoma expansion, and this will probably lead to improved functional outcome. And this was definitively confirmed in the INTERACT-4 trial, pre-hospital treatment of systolic blood pressure with uraptil. And this is the modified ranking scale shift in the hemorrhagic stroke subgroups with a very clear favorable effect on functional outcome. So let's try to dig a bit more into subgroup analysis. So what I will try to do here is to identify patients more likely to benefit from systolic blood pressure lowering, to identify patients less likely to benefit, and possibly patients where intensive blood pressure lowering might be harmful. So the first subgroup analysis that I would like to share with you is a secondary analysis of the ATAC-2 trial stratified by ICH location. So what you can see here is that there is a clear evidence that intensive blood pressure lowering reduces hematoma expansion in deeply located hemorrhages, but the authors did not observe such effect in lobar hemorrhages. So most of the evidence that we have available is suggesting that systolic blood pressure lowering reduces hematoma expansion in deeply located hemorrhages. The other important message of this slide, I think is that the confidence interval of the lobar ICH subgroup is quite large, and this is because lobar ICH were underrepresented in the ATAC-2 trial, but they were underrepresented in all the main systolic blood pressure lowering trials. And so therefore, all the randomized trials available has provided data on 80 to 85% of patients with deeply located hemorrhages, while we don't know very much about the impact of systolic blood pressure lowering on lobar bleedings. The other subgroup that I would like to focus my attention on is the subgroup of patients with very severe hemorrhages and very high presenting systolic blood pressure lowering, systolic blood pressure. So this is again secondary analysis of data to trial that focus on patients presenting with a very high systolic blood pressure, and with very high, I mean at least 220 millimeters of mercury. And as you can see in this subgroup of patients, there was no benefit in terms of hematoma expansion, but there was a significant increase in the risk of neurological deterioration and in the risk of kidney adverse events, so mainly acute kidney failure. So we don't have data on efficacy of intensive blood pressure lowering in patients with very large, very severe ICH and very high presenting blood pressure. And in this subgroup of patients, systolic blood pressure might be harmful. Another interesting secondary analysis that I would like to show is a secondary analysis of data to trial stratified by the imaging features of patients with ICH. So what we observe is that patients with non-contrast CT markers of ICH expansion, so in theory, patients at very high risk of expansion, did not derive more benefit compared to patients without these markers from intensive blood pressure lowering. The same result was obtained in an analysis stratified by the presence of the CT angiography spot sign, a very strong predictor of ICH expansion. And again, we saw that the effect of systolic blood pressure lowering was similar in spot sign positive and spot sign negative patients. So the main message is that the imaging features cannot at this stage identify patients more likely or less likely to benefit from intensive treatment of blood pressure. Of note, this CT angiography spot sign was very much underpowered because more than 80% of the patients in the ATAC2 cohort did not have a CTA for spot sign assessment. And finally, another subgroup analysis is a subgroup analysis stratified by kidney function. So as we have seen, very intensive blood pressure lowering might increase the risk of kidney failure in patients with ICH. And what this secondary analysis of randomized control trial has seen is that patients with reduced kidney function at baseline might be more likely to experience death or disability when receiving intensive systolic blood pressure lowering. So to summarize subgroup analysis, patients like this, so very small, deeply located hemorrhage, early presenter, so within 1.5 hours from onset, and high, but not super high, systolic blood pressure, is very much likely to benefit from intensive blood pressure lowering. So we have robust data on the benefit of systolic blood pressure reduction in this type of patient. We don't have very much data on this kind of patient on the right. So late presenters, we don't have data on lobar ICH, as I've already said. We have limited evidence on large volume ICH, so baseline volume above 30 mils. And we don't have robust data on patients presented with systolic blood pressure above 220. And in this subgroup, we might be a bit more careful because intensive blood pressure lowering might be harmful. What are the main challenges in clinical practice? So let's say we have identified the ideal systolic blood pressure target. First of all, it is not that easy to reach the desired systolic blood pressure target. And from this very nice analysis of Tom Mullally and colleagues from Lancet Neurology paper in 2019, we have seen that blood pressure variability, so fluctuations, were independently associated with the risk of any adverse event, death, and poor functional outcome at 90 days. And a secondary analysis, again, of the ATAC2 trial has provided further evidence confirming that systolic blood pressure fluctuation were associated with neurological deterioration and poor outcome. But this association is time-dependent, so it is very important to control systolic blood pressure fluctuation, especially in the first 8 hours from onset. The other challenge is that all the available evidence that we have on systolic blood pressure lowering in acute ICH came from randomized controlled trials that evaluated functional outcome at 90 days. We now know that the recovery trajectory of ICH is much longer and probably continuing up to 6 months or 1 year. So we might have had missed some beneficial effects because the follow-up was simply too short. So in conclusion, we do know that systolic blood pressure lowering improves functional outcome, but this improved outcome is probably evident only in a specific subgroup of patients. Early presenters, patients with small, deep ICH, and patients presenting with the systolic blood pressure in this range, so 150 to 220, are probably more likely to benefit. The next steps, there will be trials with systolic blood pressure reduction with stability as the main outcome of interest. So the effort will be to rapidly but steadily reduce systolic blood pressure, minimizing variability. We need more data on global ICH, patients with severe hemorrhages with very high systolic blood pressure. And I think we need more data on surgery. So after the ENRICH trial and recent evidence, the population of ICH undergoing the surgery is probably going to increase. And actually, we have no clue on the optimal systolic blood pressure management before, during, and after surgery. So there are many surgical trials ongoing, and hopefully we'll be able to gather some evidence from these ongoing trials. So this is all I had, and thank you very much for listening.
Excellent. Many thanks, Andrea. We have a few questions, but as far as I see these questions, we should postpone them until the next talk because they are on agents and thresholds, and I think it makes more sense if we answer these questions after the next talk. And the next talk will be on what is the role of antihypertensives in primary and secondary prevention of ICH, which will be given by Professor Trine Apostolaki-Hansson from Lund University, Steiner University Hospital in Malmö. And Trine, many thanks again to you because Else, who was first asked to give this talk, couldn't make it. And you were kind enough to step in and prepare this talk. So many thanks again.
Thank you, Thorsten, for that lovely introduction. So today I'm happy to be here to talk about the role of antihypertensives in primary and secondary prevention of ICH. I have no disclosures. So for the outline today, we will first cover, let's see how to use this pointer, the ESO EANS guideline recommendations for blood pressure lowering in the acute phase. And then we're going to move on to primary prevention of ICH and recurrent stroke and death and disability, as well as secondary prevention. And finally, we're going to touch on next steps, what needs to be clarified in future research and clinical implementation. So we'll start with the acute phase. A hypertensive response is very common in the first 24 hours after ICH onset and even the following days after this. And like Andrea mentioned, it's associated with hematoma expansion, perihematomal edema, and death and disability. So our treatment is aimed at reducing hematoma expansion, and a moderate BP reduction reduces hematoma growth, as Andrea already proposed. So the clinical question from the guidelines, PICO2, asks, in adults with acute spontaneous ICH, does blood pressure lowering to a specific lower target compared to standard or no specific target improve outcomes like death, dependency, or hematoma expansion? So for this analysis, 14 RCTs were included, comparing blood pressure lowering with control for a total of 7,300 patients approximately, and they were assessed within 2 to 72 hours of symptom onset. And when we look at functional outcomes and mortality at 3 to 6 months, the majority of the studies were performed with a 3-month follow-up. The evidence is neutral. And blood pressure lowering treatment, targeting a lower blood pressure compared to control, did not improve, did not lead to an improved functional outcome or mortality at 3 to 6 months. And we can see that there are wide confidence intervals for a lot of these studies, as well as for the outcome. And there was very low certainty of the evidence, and it should be interpreted with caution as it raises concern about the impact of study level heterogeneity. And so the effect of the analysis was also stratified according to hospital presentation. So this didn't differ within 6 hours from hospital admission, within 24 hours or 72 hours. So the findings were still neutral. What we did see was that antihypertensive treatment compared with control showed a non-significant trend in hematoma expansion in the cohorts that had follow-up imaging. When also stratified by time to treatment, we could see that for presenters within 6 hours from symptom onset, we could see that acute blood pressure lowering was associated with lower odds of hematoma expansion, and within 24 hours was not. So the ESO ENS guidelines from 2025 state that for adults with acute spontaneous ICH and a systolic blood pressure of 150 to 220, the overall balance of beneficial and adverse events is uncertain, and we therefore recommend enrollment into ongoing randomized trials. So there's no strong evidence-based directive yet, but consensus guidance is available, as we can see in the next slide. So the expert consensus gives more practical direction, and we suggest lowering systolic blood pressure to 140 within 6 hours of symptom onset in minor or moderate ICH with a volume under 30. And that's because of the majority of the studies were done. For example, the INTERACT 2 and ATTACK 2 studies had a median volume of around 11 milliliters. So it's unclear what the effect is, like Andrea said, for volumes above 30 milliliters. And this is primarily to reduce hematoma expansion, of course. So we also recommend, like Andrea said, avoiding large drops of more than 70 mmHg from baseline, and to be cautious, lowering more than 110 due to potential neurological deterioration and renal adverse events. So Andrea also touched upon the 220 level, as very high initial pressures can also lead to potentially neurological deterioration. So for the acute phase, we suggest to maintain a SBP under 140 and to hopefully attain this level within the first 2 hours following the onset of symptoms. And we also want to minimize variability in blood pressure fluctuations in the acute phase, but also up to 7 days after the ICH event. And this was a unanimous vote. 15 out of 15 experts agreed upon this consensus. And so the idea with a 70 mmHg drop is that here we can see a pooled analysis from INTERACT 2 and ATTACK 2 that showed an interesting J-shaped pattern, and that it showed that larger BP reductions above 70 within the first hour were actually correlated with worse functional outcomes on the MRS scale at 90 days. So the sweet spot was around 32 to 46 mmHg drop within the first hour. And so early and stable control for BP lowering in the absolute acute phase seems essential, and to not decrease from baseline more than 70 is probably recommended. This table was recently summarized by Adrian Perry-Jones and colleagues in the ESJ 2025, and it shows drugs that have been used in trials to lower BP and acute ICH. And in practice, I'm showing this to you because we should aim for using drugs with fast action, good controllability, and minimal side effects. So there's been a lot of attention to clevedipine because of its short half-life of 1.5 minutes. And this drug will be compared in an RCT called CLUTCH that will look at clevedipine versus standard care to see its effect on outcome by lowering it in the acute phase and to reducing blood pressure variability, and to also look at stability of blood pressure lowering. And then there's other drugs that are commonly used, but they can differ according to site level and also by country. So it's not always uniformly used. Like labetalol, for example, is much more commonly used in Sweden compared to Urapil. That might be more common somewhere else. Urapil, sorry. So moving on now to prevention. So hypertension is by far the strongest modifiable risk factor for ICH. And the European Society of Cardiology guidelines recommend that the treatment in adults with BP above 130/80 if cardiovascular risk is high. And the PROGRESS trial already demonstrated over 20 years ago that blood pressure lowering dramatically reduces recurrent stroke, and particularly hemorrhagic events. Yet globally, we see that there's poor hypertension control, and this can be due to various reasons, such as therapeutic inertia, that we see that the patient has a clinical indication for blood pressure lowering, but for whatever reason, action isn't taken to reduce their blood pressure. Ineffective drug regimens, poor up-titration of drugs, harm concerns such as dizziness, falls, in the elderly especially, and also poor adherence to the medication regime by the patient. So in this systematic review, we can see that across multiple case control studies, we can see that the odds of ICH are 4 times higher in people with prior hypertension in their medical history. So the message is simple here. If we can control blood pressure, we can help prevent ICH. And here is another study. It's a systematic review and meta-analysis that looked at blood pressure lowering for prevention of cardiovascular disease and death. And there's a clear continuous relationship seen here between the usual systolic blood pressure and stroke risk. So for every 10 millimeters of mercury reduction in SBP, we can see that the risk for ICH, or for the first ever stroke, actually, they just looked at a stroke population in general, was significantly reduced. So even mild long-standing hypertension matters. And this is another large cohort, and this one is specifically from China, including a very high number of patients from the China Kadoorie Biobank, where patients were followed for a mean of 9 years. And here it clearly shows that intracerebral hemorrhage risk rises steeply with higher usual systolic blood pressure values. So patients with a usual SBP of 180 had an HR of 12 for intracerebral hemorrhage event. So for and here's another table that shows that for every 10 millimeter increase in SBP, the risk of ICH increases by nearly 70%. So it's much stronger than for ischemic stroke or heart disease that you can see here below. So this is also a striking reminder that ICH is the most pressure sensitive manifestation of hypertension, and that even small sustained increases matter. Let's see. Yeah, so this is an observational cohort from Mass General Hospital and Hong Kong University that looked at hypertension control at 3 months and thereafter following ICH. It was an observational cohort that included 1,828 patients with a median follow-up of approximately 46 months. And BP was measured at 3, 6 months, and then thereafter every 6 months, and hypertension was actually defined here as 140/90. And it's basically real world data, and at 3 months we could see that the amount of patients that had controlled blood pressure only amounted to 39%, undertreated, meaning that they had two or less drugs and did not have controlled hypertension, was 41%, and treatment resistant, meaning 3 or more drugs, was 20%. And this shows the Kaplan-Meier curves here show the risk for recurrent stroke and mortality. And so we can see that patients that were treatment resistant had the highest recurrence of MACE and mortality, whereas patients that had controlled blood pressure had the lowest risk of such events. And we can see that poor control translate directly into stroke risks, as shown by Teo et al. Here we can see recurrent ICH and MACE based on blood pressure control after ICH. And here they looked at different blood pressure, systolic blood pressure thresholds, and saw that over 130 mmGs and over was associated with higher rates of recurrent ICH and MACE, whereas patients with systolic blood pressures under 120 appeared to have better outcomes. So in this context, in this observational cohort, it looks that as if lower systolic blood pressure seems better. So the secondary prevention PICO question, PICO 6.1, asks whether tighter blood pressure control or a particular agent reduces the risk for subsequent stroke, MACE, or death after ICH. And the consensus statement here is clear, and we recommend blood pressure control under or equal to 130/80 in patients surviving ICH as a means to reduce the risk of subsequent stroke. And the quality of evidence is low, but the strength of recommendation is strong. And there's no single best target or agent proven by RCTs. And here, the meta-analysis in this guideline included the PROGRESS trial, as well as the RESPECT trial. There were no trials at this time that solely looked at ICH as a population, so these are subgroup analysis of major RCTs. So in the PROGRESS trial, patients with a history of any cerebrovascular event were randomized to antihypertensive drug regimen or placebo in a follow-up period of around 4 years. And recurrent stroke or TIA occurred in 10% approximately of patients in the ICH patient group, in the treatment group, compared to around 18% of patients in the placebo group. So we could see here that the odds in that in the PROGRESS trial were in favor of intensive blood pressure control. And in the RESPECT trial, the numbers were obviously much less, as you can see here in the meta-analysis, and they investigated the efficacy of blood pressure lowering control with a target of under 120 compared to a standard target of 140 using a polypill for people with stroke. And there we can see wider confidence intervals. But in total, it seemed as if initiating blood pressure control in the subacute phase after stroke, after ICH, can reduce the risk for any recurrence of any stroke after ICH. And so for ICH recurrence specifically, this was based on this meta-analysis was based on a single RCT with very few patients. So it's very unsure data. And we can see here that the unadjusted OR for ICH recurrence was 0.28, but with very large confidence intervals. So the evidence here is quite uncertain. The image on the left, the figure on the left is a Kaplan-Meier curve, and it shows prescription of antihypertensive medication at discharge and how it influences survival following stroke. And this is based on an Australian cohort. And we could see here that patients discharged after their stroke event, that the ones that were not prescribed medication, antihypertensive medication, had a higher odds of death compared to the patients that were prescribed medication. And for the intracerebral hemorrhage patients, only 1/3 of them weren't prescribed any antihypertensive drugs at discharge, and even in a high income setting like Australia. So we can see that there's probably a lot of missed opportunity for patients to be put on antihypertensives in an early inpatient setting, and that this would probably result in a better control of hypertension and potentially reduce the risk of MACE. And this is also because sometimes neurologists or clinicians that take care of ICH, that they can wait and allow for the primary physician to initiate medication if they're like right on the border of being too high in their blood pressure. So we believe that it could benefit the patient to start earlier at the hospital. and have a quicker follow-up. I want to present this study as well that was presented at the WSC last week, and the study is called Triple Therapy for Prevention of Recurrent Intracerebral Disease Events trial. It's a Trident trial that was done now 2025, and it's a multi-center international double-blinded placebo-controlled randomized controlled trial that looked at a blood pressure lowering pill, a triple pill on top of standard care in patients with acute ICH and a systolic blood pressure equal to or more than 130 in comparison to standard care. And the Trident trial recruited 1,670. Their goal was 1,500 patients. And you could see in the results that were presented last week that blood pressure lowering therapy reduced recurrent stroke by nearly 40%. And that the numbers needed to treat to prevent one recurrent stroke was just 27. And for recurrent ICH specifically, blood pressure lowering therapy reduced the risk of recurrent ICH by 60%. So these numbers are very powerful, and they emphasize the fact that that secondary prevention is very important. So to summarize, as was already mentioned several times, the goal of blood pressure lowering in ICH is to limit hematoma expansion and to target 140 quickly within 1 hour and within hospital admission, and preferably within 6 hours of symptom onset, and to minimize variability for the first 7 days, and use fast-acting drugs with good controllability and minimal side effects, and to be cautious with over 220 SBP and to avoid large reductions and avoid going below 110. And like Andrea mentioned, a lot of these studies for blood pressure lowering were done with a 3-month follow-up, but we have seen that ICH patients can improve up to a year from changing from an MRS 4 to 5 to an independent in approximately 40% of patients. So we believe that a 3-month follow-up is way too early for patients with ICH. And I haven't had time to go into care bundles, but they can provide a synergistic effect. A care bundle is when you provide several different acute therapies at ICH presentations, such as acute blood pressure lowering, anticoagulation reversal, and access to treatment for hyperthermia and hyperglycemia, and to avoid care limitations such as is proposed in the ongoing iCatcher trial that we've recruited approximately 450 patients. And we believe that the synergistic effect of all these different combined treatments can improve patient outcome. And this was seen in Interact 3 trial that I have also not mentioned here, but that employing a care bundle approach to patients with ICH has been shown in a primarily Chinese and Brazilian population that it can improve outcome. And a mediation analysis was recently performed in 2025 on the Interact 3 population that showed that the blood pressure lowering and the treatment of hyperglycemia were actually the driving factors in that trial. So for secondary prevention, it's important to target below 130/80 to avoid MACE, including recurrent ICH after an ICH event. And we recommend early inpatient initiation of treatment and to reduce therapeutic inertia, so that when we see that high blood pressure, that we take action and treat it and send it to the primary physician to follow up, and even to encourage the patient to have at-home blood pressure monitoring and to report back to their physicians about their blood pressure levels. Also, blood pressure can also influence the resumption or initiation of antithrombotic treatments, which is also very important for patients with ICH, because a lot of patients with deep bleeds and have higher risk factors for other types of ischemic events. So it's a very important that blood pressure is under control on patients that are going to be put back on antithrombotics. So that's an individualized risk versus benefit type approach that you have to look into there. And to also consider single pill combinations, which could make adherence easier and potentially improve long-term outcomes, as was seen in the Trident trial. Yeah, so that's everything I have for today. Thank you.
Thank you, Trine, for this wonderful presentation. And again,
Thank
for
you.
stepping in and giving such a high quality presentation. Many thanks.
Yeah, no worries. Thank you.
We have a couple of questions, and some of them have been answered already. So one of the questions is, where is it? Yeah, it's about, do you recommend any specific drug to reduce blood pressure in the first 2 hours?
I don't know how it is in Italy, Andrea. I can tell you my experience in Sweden.
Yeah, please go ahead.
So for Sweden, when a patient comes in at my center, for example, we generally use labetalol because that's the drug of choice here, and that's a drug that's more available. So we usually go with 30 milligrams of labetalol for patients presenting with very high blood pressure. And then we take a new blood pressure around 5 minutes. If it's still high, we give them 20 more, and then we start an infusion of 100 milligrams per hour. And then we can adjust that depending on what their blood pressure levels are. But we have seen that that is very effective in lowering blood pressure without having different drugs like clobetapine, because that's not available in our neurology facilities. And then usually if like our patients are still hypertensive during the labetalol infusion, we usually provide dihydralazine in bolus doses that you can repeat every like 15 minutes or something. And if that's still not enough, or if the patient has like contraindications for labetalol, sometimes we switch to hydralazine infusion. Yeah, and if you don't have hydralazine, then in Sweden we also can use clonidine. Sometimes you can have a rebound effect if you use too much clonidine, but if you go with like 75 micrograms IV, this usually helps. Yeah, and there's various other drugs that can be used as well. So it all depends on what drugs are available in your facility.
Okay, Andrea, would you like to comment on that?
There is another question that is, there are some drugs that we should avoid, for instance, vasodilators.
Yeah. Yeah, absolutely. Andrea, do you want to answer or should I?
Yes, I think nitrates should not be the first choice. So my experience is quite similar. So I think the main message is to use short-acting IV drugs like labetalol and urapidil. And after boluses, it's important to have a continuous infusion to have a smooth reduction and avoid rebounds.
Absolutely.
Another question is, what about patients with high blood pressure and ICH with ICA stenosis?
Yeah, that's a good question. So it depends how high the stenosis is. If it's like if it's a very high stenosis level, I would be a little bit more cautious to lower the blood pressure, especially if it's bilateral stenosis. But if it's a patient with like mild, moderate atherosclerosis in their internal carotid arteries, I wouldn't be as careful. And also, there's not very much evidence regarding this because in the past, it hasn't been so common to do CTA on all patients that come in with ICH, and that's changing. We're doing more CTAs because of the spot sign to identify AVMs and to improve diagnostics. So I don't think any studies have really looked at that, Andrea.
Yeah, I basically agree. I think the red flag should be bilateral, severe carotid stenosis. But I also think in these patients, if you reach a target of 140 to 150, it might be beneficial on the ICH and enough to provide a good perfusion of the remaining of the brain. So you just need to use your clinical judgment, but I would probably treat the blood pressure despite the stenosis.
Yeah. Yeah, if it was a high-grade stenosis, I would do the same as Andrea, not below 140, 160.
Okay. Another question is for you, Andrea. Is there any difference for lowering blood pressure in specific cases, like cases with ICH, but also intraventricular hemorrhage or infratentorial hemorrhage?
Well, the rationale is to prevent expansion, which is common across all locations. So I would not treat them differently. So we have very limited data on infratentorial from randomized controlled trials. And we have very limited data on cerebellar ICH that might receive surgery. So we need data on these subgroups, but I cannot recommend something different from the guidelines that Trine has showed.
There is another question, which I think is also of practical relevance, and that is, for how long can we give IV blood pressure agents and switch to oral drugs? Would you like
Yes,
to
so
comment on
I can
that?
answer. So for at our clinic for labetalol, for example, we continue with the infusion until we see that it's stable, and we also initiate oral drugs as fast as this patient can swallow. We also look at other avoidable risk factors like stress, pain, if they have urinary urgency, to treat these types of avoidable factors that can also potentially affect the blood pressure and lead to spikes in their blood pressure. But for infusions, we generally continue with the infusion until the blood pressure is stabilized. We have arterial lines so that we can see this stability. But in other centers, of course, you maybe don't have an arterial line. But we generally continue with the infusion until we see that it's stable.
Another question is, without a new neurological deficit, how often should we control a CT scan?
Well, I can answer this. I think the main implication of a follow-up CT scan is to demonstrate that the bleeding is stable. So if you need antithrombotics or low molecular weight heparin for whatever indication, you are probably on the clear side. And then I would follow the clinical evolution of the patient. So I know that in some countries, there is not a routine of follow-up CT. So I usually obtain it at 24 hours or earlier in case of neurological deterioration. But then you can go with your clinical judgment, and there's no need to keep doing scans.
I agree.
Here's one question. I think we have answered it, but maybe we can point that out again. What is our opinion on using nicardipine as first choice drug in the acute phase?
Well, it's not the first choice, at least in many countries, and in many countries it is not available. But if that's the main agent, it's better to use nicardipine than to do nothing. So my recommendation is treat the blood pressure with whatever you have, possibly avoiding nitrates, but it's important to treat the blood pressure and to bring it down with whatever you have available or with whatever you are used to work.
Another question that is really hard to answer is, what is the blood pressure target in secondary prevention of CAA patients with ICH?
Yeah, so I would probably, for CAA patients with ICH, I would probably aim for like 120. They generally tend to have much lower blood pressure, the CAA patients, when they come in, is what I've experienced. But I would generally probably go to around like 120 if they weren't at any other risk for falls or anything like this. But there's no like general recommendation, I think, for CAA in general, but definitely under 130.
Yes,
And
I
especially
agree.
if this patient is for whatever reason on any type of antithrombotic treatment, there's a relative contraindication for antiplatelets. So if they're on an antiplatelet, then I would hope for maybe 120 instead of 130.
Here's another question, which I think is of practical relevance. How do we deal with large hematoma in acute phase with possible increased intracranial pressure? Maybe Andrea, you would like to comment on that?
Yes, very large ICH patients typically have a blood pressure above 220. So we need to be a bit more careful in this subgroup because they are at high risk of increase intracranial pressure. If you work in an ICU setting, and if you had the possibility to do, one way would be to measure the intracranial pressure to know what's going on. And in general, I think these are patients less likely to benefit from systolic blood pressure lowering down to a target of 140. So I think a milder reduction might still be helpful.
Another question is, given that trials of blood pressure lowering alone, when tested in isolation and that have not consistent, convincing results, when we look at care bundle trials as Interact 3, do we think the results are driven mainly by the nursing care, for instance, the location of the trial?
So that's a really good comment and a really good reflection, and it could possibly be that the increased attention on the ICH patient in general can lead to better outcomes. Absolutely, it can also be like in the prospective trial from Adrian Perry-Jones that they showed that withdrawal of care orders, if we remove the withdrawal of care orders for ICH patients with the acute phase setting, that this was shown to improve outcomes in his study. So I don't think it's only the improved nursing. I think it's the combination of everything, but that's my personal opinion. And I think that, like Andrea mentioned, that there's certain individual patients with ICH that will benefit from blood pressure lowering treatment. We believe that being active in the acute phase is extremely important to help limit hematoma expansion in the patients that are responders.
Okay, then there is a question on the 70 millimeters difference, 70 millimeters of mercury difference. Would we recommend to not lower by more than 70, depending on the starting point?
Yeah, so that there was that sub-analysis of the Interact 2 and Attack 2 trial showed that above 70 was harmful to patients. This is a sub-analysis from an RCT, so I believe that it requires more evidence, but it shows compelling results showing that large blood pressure reductions over 70 can be harmful to the patient. So patients that come with very high blood pressure are usually those patients that will have that 70 mmHg fall. So those patients above 220, particularly, we have to be a little bit more careful with, we believe, to not decrease CPP, cerebral perfusion pressure.
Another question is the target of blood pressure lowering the same in ICH regardless of anticoagulation reversal needed or not?
Well, that's a very good point. We might assume that given their very high risk of expansion, they should be treated very intensively, but actually we don't have very much data to prove this, and this has been recently reviewed in a nice European Stroke Journal paper. So my personal opinion, but take it as such, is that they should be treated intensively, but it's just an opinion because there were very few patients on anticoagulation in randomized trials.
Okay.
Thank you.
Furosemide. Is furosemide appropriate for increased intracranial pressure?
What was the question? Is
Furosemide, diuretic drug.
Yes.
Diuretic drug. Is that appropriate for increased intracranial pressure treatment, I guess?
I would say no. And we know that ICH patients are at high risk of kidney failure, and using diuretic agents in the acute phase might add some harm. So I can't recommend it. I would say no.
Yeah, I agree. And all the RCTs, they don't use diuretics in their trials. So I would not use it because it just lowers the blood volume. And dehydration can contribute to renal adverse events like Andrea's mentioning. So no, I would not use it as well. I would use this as like a last resort treatment. But you can use it in the secondary prevention, of course.
And people asked also about the use of tranexamic acid or dexamethasone in ICH. Could you?
So
Do you want me to answer that question or?
Yeah, feel free to go
doesn't
ahead.
matter.
Okay, go ahead, Trine.
It's important.
So for tranexamic acid, the evidence has been neutral, but we still believe that if maybe patients are given treatment very early, so the TIH3 is going to look at 4.5 hours from symptom onset, and we still have a belief that it may help for those very, very early patients that come. But as of now, there's no clinical evidence that shows that tranexamic acid is beneficial for our patients. That's my answer on TXA.
There, any comment?
No.
And there
same.
was the question on dexamethasone. Actually, a very nice idea. There is only one randomized controlled trial testing it from 1989, published in the New England Journal of Medicine, and that did not show that dexamethasone has an advantage, a clinical advantage, though the time of application was within 48 hours. And the question is totally open whether a very early application of an immunological drug might have an influence or not. But so far, the answer is no.
I think we have no time for further questions, and I have we have to close the webinar, and we have to thank the speakers for this great presentation, very, very interesting. And I don't know if Thorsten, you want to add something?
I also would like to thank Trine and Andrea and you, Anna, for putting this together. It was a pleasure.
And
That's it.